Good afternoon, everyone. This is Amy Gibson with the Patient-Centered Primary Care Collaborative. Welcome to our webinar today. Today, we are going to be talking about partnerships between clinicians and community-based organizations to improve patient outcomes. As many of you know, we have been awarded a support and alignment network through the Transforming Clinical Practices initiative sponsored by CMS. And one of the priorities that we have as part of our STAN grant is to work with community organizations and clinicians to help them better align their services in a way to help share accountability for a population of patients. And that can take lots of different forms, but one of the biggest challenges that we've seen is clinicians in a lot of places aren't aware of a lot of the programs that are available out in communities that are really helping patients manage their chronic conditions. So as part of TCPI, we're going to be partnering with the YMCA and many of our other members of the PCPCC to really try to highlight where there's some successful partnerships in making this happen so that clinicians and community-based partners are really working jointly together to improve population health. So I'm not going to take much more time other than to let you know how we run our webinars for those of you who have not participated before. We don't take audio questions, but we do allow you the option of typing in your questions in the chat box. And at the end of the presentation, I'll be facilitating questions and answers with our speakers. So at any point during the webinar, you can type in your question, and then time allowing, I'll be asking those questions of our presenters. We'll also have this webinar archived up on our website so that you can access it at any point after today's live presentation. We'll have a full recording along with a copy of the slides. And if there's any links to other resources mentioned on the webinar, we'll have those posted as well. So please do forward information about this webinar to your colleagues who are not able to participate in the live version today. And we'll have those available up on our website. Any other technical questions you might have, you can also type into the chat box, and we'll do our best to facilitate helping you out with that. So I'm going to go ahead and kick it right over to our presenters today. We have Dr. Matt Longjohn from the YMCA and Omar Hassan from the AMA, and I'll let them introduce themselves a little bit more. We also have their full biographies on our website as well. So Matt, why don't you go ahead and take it away?
Will do. Thank you, Amy, and I'll let Omar introduce himself in a couple slides, I think. Thanks everybody for joining the webcast. The YMCA of the USA is a proud partner of the Patient-Centered Primary Care Collaborative, and not just in this SAN grant, but also on the executive committee of the organization. We're proud to be connected to Amy and Marcy and everybody at PCPCC. As the slide shows, I'm Matt Longjohn. I'm the National Health Officer and Vice President of Evidence-Based Health Interventions at YMCA of the USA. I'm the first physician executive in place at the National Y in its 170-year history, which reflects the changing nature of the Y and our intent to be better partners to those of you focused on population health and transforming your practices to address population health through clinic to community linkages. Our talk today is going to follow this basic outline here. I'll give just a slide or two of background information on the Y, and then talk about the history of the YMCA's Diabetes Prevention Program, which is an example of the CDC's National Diabetes Prevention Program. After going through some of that history, I will summarize the results of a recent Healthcare Innovation Award that the Y was a part of with the Centers for Medicare and Medicaid Innovation. And then I'll turn it over to Omar to talk about the AMA's role in that project and to share some key learnings for all of you as healthcare providers about what the most effective way was or ways were to partner with Ys in the enrollment of people with prediabetes in this evidence-based intervention. And then I'll take the controls of the webcast again for some final slides on thoughts on the broader ramifications of this one successful project and this one program for all of you as TCPI providers, and we'll, I think, have a good amount of time for question and answer at the end. So the YMCA as you might know it, might be a building where you drop your kids off for swim lessons, or maybe where the family goes for family camp. But we are a federated nonprofit network. There's one Y, but there's almost 900 separate 501c3s that are represented on this map, and that are the local associations of our national movement. As a 170-year-old organization, we're actually one of the nation's oldest and largest charities. And as you can see on the screen here, we not only have nearly 900 nonprofit associations that make up the Y, that sign on to the charter and agree to subscribe to our mission of healthy spirit, mind, and body. But also, because so many of our programs are delivered outside of YMCA buildings, and because all these associations may have as many as 40 buildings themselves, it ends up that we have program locations in over 10,000 sites. And just if you think about our buildings, there are about 2,700 buildings or facilities, and about 80% of U.S. households live within 5 miles of one of those facilities. Again, we deliver so much of our programming outside of those facilities that we are closer to a greater percentage of the U.S. households than the statistic I just shared. But we recognize our role here is potentially a great service delivery system for partnership for population health, and that kind of awareness and that awakening in the Y movement transpired about 10 years ago, and was the basis for us beginning to do work in evidence-based program delivery, as exemplified by the YMCA's Diabetes Prevention Program. The way the Y thinks about healthy living and its work in healthy living through the application of a couple different public health models. You'll recognize on the top of this framework that I'm sharing the components of a socio-ecologic, where to address population health and public health challenges, we must address those issues at the individual level, the family level, the organizational level, the community level, and at the societal level through policy systems and environmental change concurrently. And the Y is one of the few organizations, not just with a national footprint, but also with a commitment to working at all of those levels of the socio-ecologic model. Additionally, in recent years, we've been working down the framework as well, where in addition to what we're most known for, the programs in the upper left, family camp, aquatics, personal training, etc., that are all primary prevention programs. They're good for everyone's health. We are now also investing and innovating to deliver programs that are secondary prevention programs or even tertiary prevention programs. And while today I'll talk about the Diabetes Prevention Program, which is a secondary prevention program, there are almost as many cancer survivors coming to the Y these days for our tertiary prevention program, a cancer survivorship program called Live Strong at the YMCA, as there are in the Diabetes Prevention Program. So again, this will just be an exemplar of how one might work with a community-based organization like the Y. The YMCA's Diabetes Prevention Program is a year-long program for adults with prediabetes. We really do not allow folks into the program who already have diabetes or who cannot meet the definition of prediabetes here as recognized by the CDC, either via one of 3 blood tests, fasting plasma glucose, glucose tolerance test, or A1C, or without scoring a 9 or greater on the CDC or American Diabetes Association validated risk assessment tool. The program, as I said, is a year-long program. It begins with 16 core weekly sessions and is ultimately followed by 8 monthly maintenance sessions. These are 1 hour in length. They are group-based interventions where in a classroom setting, 8 to 15 people get together and are facilitated as a group by someone trained in HIPAA compliance and motivational interviewing and group facilitation to identify barriers to healthy eating, physical activity, and other lifestyle modifications. And as a group, support individuals taking accountability for behavior change, and producing, on average, 5 to 7% weight loss and 150 minutes of physical activity a week. This program is delivered anytime, anywhere. All you need are some chairs, ideally a table, and a place where participants are willing to show up. It's not always delivered in the Y. In fact, the majority of our 1,500 current program sites are outside of a YMCA. We will go to church basements, employer break rooms, FQHC conference rooms, school cafeterias. We've even delivered the program in an auto dealership. So any place where people are willing to show up is where we will deliver this intervention. Our lifestyle coaches are trained to deliver the intervention. They take a backpack, a laptop, a scale, and they will go, again, as I said, wherever people will show up for the program. They bring the scale because every individual participant must weigh in at every session, and that reading, as well as the person's attendance and their tracked behaviors, are recorded for every individual for every session in the 24-session program within 24 hours of that session. And we record all our data in a HIPAA-compliant electronic medical record and are able to share that with clinicians in the clinical record. It's an automated process so that we can become part of the integrated care team. That system is also actually a claims processing engine. We do have, as of January 1st, a CPT code for this program that allows non-licensed providers to deliver this standardized intervention. It's a Category 3 CPT code, 0403T. And by the end of this year, there will be 300 YMCA associations, each with their own national provider ID. So by partnering with healthcare, using an EMR and all these bits of infrastructure, we can really be part of a community integrated health system. As I move forward here, I'll tell you quickly the history of this program. It began with an efficacy trial. The NIH spent about $200 million on the Diabetes Prevention Program trial. This was published in the New England Journal back in 2002, and it showed that this lifestyle intervention, the program that the Y licenses from the original investigators at the University of Pittsburgh, produced a 58 to 71% reduction in new cases, incidence of diabetes. And compared to metformin, there was obviously a very statistically significant improvement in the risk reduction outcomes of this for this population. So much so, in fact, that for ethical reasons the trial was ended early, and in an intent to treat model, all of the roughly 3,000 participants ended up getting the lifestyle intervention, the exact same intervention that I described on the previous slide. By achieving an average of 5 to 7% of weight loss, these participants are obviously reducing their risk for type 2 diabetes. An interesting note, as I flipped the slide already, is that for the older population, the intervention is even more effective than in the general population. That's where that 71% reduction in new cases of diabetes was shown. Also, interestingly, there's been as much as 10-year look-backs looking at that same population and showed sustained effect at 10 years for those trial participants. In Chapter 2 of our story of the development of the YMCA's Diabetes Prevention Program, with support from the CDC, there was another study, the Deploy study, and the NIH funded this. Excuse me, I said CDC. The NIH funded this. And some of the original researchers, led by Dr. David Marrero and Ron Ackerman at Indiana University School of Medicine, partnered with the YMCA of Greater Indianapolis. And they said to the Y, this intervention has been shown to work in the clinical setting. We're wondering if the Y could produce the same outcomes. And as you can see on your screen, the Y did achieve, and in some ways at a greater degree, the weight loss and other outcomes from the original trial. In particular of note was that in that study it was shown that the Y was delivering the intervention at about 20% of the cost that was seen in the NIH trial when it was delivered in the clinical setting. So same outcomes, but much lower cost, i.e. better cost effectiveness, even potentially cost savings, as you'll hear. In Chapter 3 of our story, the CDC really got invested in this with that much evidence. The CDC, under the Affordable Care Act, established the National Diabetes Prevention Program, and this basically standardizes the methods of training for a workforce to deliver the diabetes prevention program. It recognizes providers who meet quality performance requirements and who submit data to CDC every 6 months to maintain that kind of recognition credential. The CDC has been able to actually fund the development of organizations like WISE to deliver the program in more and more sites, and also manages national networking marketing, often in partnership with organizations like the AMA and the Ad Council, as Omar may speak to in a moment. But the YMCA was an inaugural partner, and our YMCA's Diabetes Prevention Program is a component of the CDC's National Diabetes Prevention Program. That infrastructure was really important to set up in Chapter 3 of our story. In Chapter 4, the Y actually was able to begin scaling this program not just with CDC support, but with support of over 30 health insurance companies who began to reimburse the Y for this program using value-based contracting. The Y is only reimbursed when outcomes are achieved. And so we have real incentive when working with those who are insured and who are covered with this benefit to help them achieve success. As a charity, we never turn anyone away for inability to pay, regardless of what their insurance status might be. And in fact, almost 20% of our participants are low-income participants based on federal poverty guidelines. As not only one of the largest providers of this service nationally, we're very proud from a health equity standpoint that we've translated the program into English, Spanish, Mandarin, Korean, Portuguese, American Sign. We've recorded it for those who are visually impaired, and we're committed to delivering this program wherever we can. You know, we have a greater proportion of low-income participants than anyone else that I'm aware of that's produced this program at scale. We're in 45 states, 1,500 program locations, and that number is growing every day. At ymca.net/diabetes, you can always find a current listing of Ys that are delivering this program. In the last couple seconds here, before I transfer over to Omar, in Chapter 5 of our story, a big hallmark of the last couple years of our work has been our partnership with CMMI. We were one of 107 awardees in the first round of the Healthcare Innovation Awards. In this project, we served nearly 8,000 Medicare beneficiaries with this intervention that I've been describing. We were working in 17 markets in 8 states to demonstrate the potential cost savings of this intervention. And the data that I'm going to show with you here are data as of the end of December of 2015. And the disclaimer on the screen says that the analysis is ongoing. But with permission from CMMI, I'm sharing kind of interim program data. We were seeing greater attendance in this older adult population than we see in our normal kind of entire national population, the normal distribution of our participants. And in all cases, we are exceeding the CDC's quality metric of having an average of 9 core sessions attended in a 16-week period. For those who had Medicare or Medicare Advantage benefits covering this program, we were actually averaging 13.6 out of 16 weekly sessions attended for these nearly 8,000 participants. And because dose matters, the outcomes were also better in this participant pool than we see in our national sample. And again, this reflects the same kind of success that was seen in the original NIH trial. Older participants tend to do better in this intervention. So it may not be any surprise that the outcomes that we saw around cost savings were also good. Before I get to that slide, I want to thank the American Diabetes Association, the American Heart Association, the American Medical Association, the National Association of County and City Health Officials, National Council of La Raza, National Council on Aging, partners who helped develop the referral mechanisms for this program. And as we were going to senior centers and other community organizations to deliver this program, the importance of a healthcare referral became very crystal clear. Omar will talk about this, but we ended up getting a 17% yield on every referral from a healthcare partner in this program, That's a big jump from how we see things in the rest of the population, speaking to the importance of the clinician and of the provider for an older adult population. In terms of actual cost savings outcomes, you may have seen the news in late March. On the 6th anniversary of the Affordable Care Act, Secretary Burwell released the first 15 months worth of claims data that came out of this intervention. And it showed that for an average cost of roughly $500 per participant, Medicare was able to demonstrate in the actual claims history, the spending of Medicare on these beneficiaries, a net cost savings of $2,650 per participant. That is almost a 5-to-1 ROI in 15 months. With that, I'll turn it over to Omar.
Thanks, Matt. I'm sorry, I flipped the slide. My name is Omar Hassan. I'm the Vice President of Improving Health Outcomes at the American Medical Association. I'm a primary care physician by training and practiced for more than a dozen years before coming to work for the AMA. I do not have any relevant financial disclosures. I'd like to take a moment to review the recently released U.S. Preventive Services Task Force recommendations for screening for abnormal blood glucose and type 2 diabetes, because this is relevant. These guidelines are now out there and they're applicable to patients across the spectrum, across all specialties. So the USPSTF, after a very exhaustive review, found that individuals aged 40 to 70 years who are overweight or obese should be screened for abnormal blood glucose, and people who are high risk should be offered or referred to intensive behavioral counseling interventions to promote a healthful diet and physical activity. And the interventions that are being described here that were in the text of this recommendation statement are the Diabetes Prevention Program, which we have just heard about. Now, this is a grade B recommendation. The risk assessment that was included in the recommendation included risk factors such as overweight and obesity, a high percentage of abdominal fat, which means high waist circumference, physical inactivity, and smoking. So this would basically be my entire primary care patient population. The screening tests that I think Matt described were hemoglobin A1C, or fasting plasma glucose, or an oral glucose tolerance test. The ranges for these to qualify for abnormal glucose are 5.7 to 6.4% for hemoglobin A1C and between 100 and 125 for fasting plasma glucose. Now, the same year, which is 2015, the Community Preventive Services Task Force also did a fairly exhaustive review of the impact of combined diet and physical activity promotion programs to prevent type 2 diabetes. And this systematic review also concluded that combined diet and physical activity promotion programs such as the Diabetes Prevention Program are effective at decreasing diabetes incidence and improving other cardiometabolic risk factors such as high blood pressure and hyperlipidemia. On the basis of this systematic review, the Community Preventive Services Task Force recommended combined diet and physical activity promotion programs for people with prediabetes. And this is highly relevant because for people practicing primary care out in the community, these two recommendations together from the United States Preventive Services Task Force and the Community Preventive Services Task Force mutually reinforce the need to do widespread universal screening for abnormal glucose and type 2 diabetes, and for taking steps to enroll such individuals who are at high risk in appropriate, structured, evidence-based lifestyle change programs. Now, I'm going to take a slight detour and provide a little bit of background about community clinical linkages. There are many types of linkage interventions, but I think the ones that are most germane to the kind of work that we are doing in diabetes prevention are referral of patients from clinical practices to a community partner, or referral of patients by clinical practices to health resources in the community. The reference for this citation is at the bottom of the slide, but the article that this was taken from describes in great detail the evolution of clinical community partnerships for health promotion and for disease prevention, and I recommend that highly to people who have interest in this area. Now, one of the manuscripts that informed the design of the AMA work and continues to play a role in defining the interventions that we work on, was an article by Edson, Cohen, and Wolf, which speaks to bridging primary care practices and communities to promote healthy behaviors. And in this very detailed manuscript, the key features that need to be present in a primary care delivery setting, as well as in the community to enable effective community clinical linkages, are described in detail. And they merit repeating for this talk. In primary care, there must be a capacity for risk assessment, the ability to identify a population or a segment of the population that is high risk for a chronic medical condition. There must be the ability to offer or to provide brief counseling so that people who are high risk understand their risk status and, more importantly, understand the options available to them in the community. And then the practice must have the capacity and the ability to refer these individuals to appropriate community-based programs or resources. And finally, for all of this to work, there must be a high level of awareness among the care providers in that primary care setting of the availability of community programs. I want to direct your attention to the community resources side of this. If all of these things are operational within the primary care setting, there must still be a reciprocal setup in the community. The appropriate resource, in this case the Diabetes Prevention Program, must be available in sufficient quantity to meet demand. It must be affordable, and moreover, it must be accessible to the individuals who are in need. Finally, it must also be perceived as value added, both by the clinical practice as by the individuals who are being directed to this community resource. Now, the most interesting part of this figure is the bridge, because that's where I believe the AMA and professional medical associations have a role to play. Even if you have a primary care practice, an environment that is very resource rich and is able to perform all the activities in the left side of this slide, and you have sufficient availability of community resources, that may not be sufficient to achieve the kind of success that's needed to improve community clinical integration. You need connecting strategies. In this case, there has to be an integrator who can pre-identify community resources and explain the quality of the service and the expectations around the community resource. There must also be a way to convey information about how the referrals need to be made. There perhaps may need to be paper or electronic databases that speak to the availability of the community resources, or perhaps in some way connect the primary care referral apparatus to these community resources intake processes. And finally, there may be external intermediaries that may need to be engaged, providing a single point access to resources out in the community. And I think, as we have seen in the case of diabetes and the growing interest in diabetes prevention, many of these connecting strategies are being put into effect in different ways. Now, I'm going to get down to the work that we did with the practices in the Healthcare Innovation Award that Matt just described in more detail. And in order to orient you to what this kind of work entails, I want to walk through some numbers which I think for most of you will make good sense. If you imagine you have 1,000 people in a practice or a panel who are aged 18 to 64 years, we know that the prevalence of prediabetes is approximately 37%. And at the AMA, we've analyzed 18 to 64-year-old healthcare enrollees in private health plans. So we use the commercial, the MarketScan, Truven MarketScan database to estimate the prevalence in the commercially insured population. So of these 370 who have prediabetes, under good circumstances, I know that the statistic that Matt shared was 17%, but we, the AMA, in our work with practices have found that enrollment rates of up to 30% can be achieved given enough time, and if there is a payment source for the program. We can estimate that about 111 individuals will enroll in the Diabetes Prevention Program, and I added the caveat there with MD or practice involvement. But take note, the range here could be from 10% up to 50%, meaning with intense involvement like a maybe nurse case manager calling up patients to notify them of their high-risk status, and with perhaps outreach from the Diabetes Prevention Program, enrollment rates of up to 50% are achievable. We have seen that happen. But without a lot of these factors in play, the enrollment may be as low as 10% or even in the single digits. Now, Of these 111 individuals, approximately 67 will end up completing the diabetes prevention program. I can share with you that I think the results at the YMCA are even better than that. I believe they have completion rates in excess of 80%, but I'll leave Matt to give you more information about that. In general, we have seen a range across different providers between 40 to 80%, and if you split the difference, we can say that 60% of the people who enroll in the program will definitely end up completing it. And among those, we are seeing currently for many programs, and these are not specific statistics about the YMCA, I want to give that clarification. These are just the general experience that the AMA team has had in talking to programs and talking to practices more certainly. We estimate that about 50%, probably more, can achieve the weight loss target. Now we know that completing the program can lower diabetes risk by more than a third. Looking at this figure in its totality, I think it will be evident that increasing enrollment and completion rates in the diabetes prevention program is critical to the success of this type of intervention. Now, the AMA collaboration with YMCA under the CMMI award occurred between 2012 and 2015. We helped to connect 26 clinical practices to local YMCA-based diabetes prevention programs. You've already heard the numbers. We supported clinical practices with screening, with testing, and a referral, working closely with state and local medical societies. A key part of what we did was to clarify the diabetes prevention program structure, assure the clinicians and the caregivers and the patients as well of the fidelity of the program and the anticipated benefit based on the evidence, and also to prepare people for the expectations of what might be in the program. More importantly, we strengthened the existing relationships between practices and local YMCAs. We found in almost all cases that these types of relationships already existed, but we had to clarify the new and emerging role of the YMCA in diabetes prevention. And I have to acknowledge that the YMCA staff were tremendously supportive. They had a strong role in boosting both enrollment and completion rates, and I'll speak to that in a little more detail. I wanted to share with you some of the tools that were created as a part of this experience. I have to acknowledge the contribution of the YMCA, Matt Longjohn and others on his team and at YMCAs, as well as clinical practices across the nation in helping the AMA create tools which are not only evidence-based but also have the input of frontline caregivers, patients, participants in the program, and the program provider staff. These tools can be used by primary care practices to engage healthcare teams, to identify high-risk patients, to educate and engage patients, refer the patients to their local programs. There's clarification offered around the program structure and expectations. We also have a suite of CME and PICME, as well as an MOC Part 4 certification program built around goings-on within a practice that can help and identify the high-risk patients and enroll them in diabetes prevention programs. The MA has also done some work to provide guidance for diabetes prevention program providers as well as for health insurers. With the leadership of the YUSA, there is now a Category 3 CPT code that diabetes prevention program providers can use for billing purposes. This can also be used in a value-based purchasing framework. There's also a cost savings calculator which can be used by health systems as well as by insurers and also by diabetes prevention providers to estimate potential financial savings by investing in diabetes prevention. This full suite of tools is available through the website preventdiabetesstat.org, and these tools, I want to acknowledge, are they were jointly developed and are co-branded with the CDC. I think this will be of interest to many of the listeners as to how efforts around diabetes prevention can also help you meet the standards, the 2014 NCQA Patient-Centered Medical Home Standards. Now, obviously there is a standard around having a practice team, and I can share with you that this kind of work, identifying at-risk individuals and then connecting them to community-based resources for prevention, is a team sport. This absolutely needs input from all the members of the care team, medical assistants, front office staff, people who are on the IT side, people who are in filing medical records. Now, there are three areas where this doing diabetes prevention can help you get the points needed for meeting the PCMH standards. Now there are 20 points under population health management, and there is a must-pass criterion around using data for population management. You can check that box if you're doing diabetes prevention. There's a critical factor component of implementing evidence-based decision support. I would offer that the U.S. Preventive Services Task Force implementing that into the EHR system or into the IT infrastructure of your practice would help you meet this criterion. Care management and support, which also counts for 20 points under the PCMH criteria, the NCQA standards. There's a critical factor around identifying patients for care management, and there's also a support factor related to supporting self-care and shared decision-making, and these criteria can be met by working on diabetes prevention using many of the tools that I just described on the last page. Finally, there are 20 points in the NCQA standards that relate to performance measurement and quality improvement. And although there does not currently exist a measure of clinical quality performance around screening for abnormal glucose or referring into programs, the Maintenance of Certification MOC Part 4 module created by the AMA, which qualifies for American Board of Family Medicine MOC credit, does include a measure that was tentatively structured to help with meeting the MOC requirements. So in a nutshell, engaging in activities that relate to identifying people with prediabetes and making efforts to enroll them community-based diabetes prevention programs can help a practice meet the National Committee for Quality Assurance 2014 Patient-Centered Medical Home Standards as well. This is a very important slide. I wanted to share with you many of the lessons that were learned by the AMA team as members of my staff and myself went out, traveled across 8 states, 17 communities, working with 26 clinical practices. We heard a lot of feedback. We helped the practices work through some of the barriers, and this is a distillation of all that we learned. First and foremost, integrating screening and referral into practice workflow is key to success. If this work is perceived as burdensome or something extra that the practice staff need to do in their spare time, it will not take off. So teamwork is of paramount importance. We found that in many cases, tasks related to implementing a screening and testing and referral program within a practice could be conducted by medical assistants so that the physician did not have to be the one doing all the activities. We also found in many cases that community-based organization staff, and I'm talking here about the YMCA Diabetes Prevention Program staff, particularly the healthy living directors and the local YMCA alliances, could even function as part of the extended care team, interacting with the practice manager, perhaps communicating with the medical assistant or the RN case manager responsible for communicating with the at-risk population. Secondly, querying the electronic health record to generate lists of patients with prediabetes and then contacting them via phone or email can substantially increase program enrollment. As I said earlier, to reap the full benefits of such a program, you need to target high enrollment as well as high completion rates. And enrollment can be increased by having a list of patients, communicating with those patients on an individual basis if possible. This can be done through form letters which have the patient's name printed on them and the signature of their primary care physician at the bottom, or an HTML format email. This can substantially increase program enrollment. And now I'm going to give you the secret of getting the highest rates of enrollment. We found time and again that in situations where the practice reached out to the patients by email or phone call or literally by snail mail, mailing a printed letter, and this was followed by outreach from the community-based organization, the YMCA Diabetes Prevention Program staff. In those scenarios, the enrollment numbers were the highest. If the practice can inform the patient of their risk status and make them aware that they should expect to be contacted by staff from the local YMCA, and there is subsequent outreach from the local YMCA, we think you can achieve the highest rates of enrollment. Now, I want to share that EHR alerts had a mixed reaction. We had at least two practices in which EHR alerts were embedded in the EHR, and that prompted clinicians to refer patients because the screening was factored into the alert when the eligibility criteria were met. This, among enthusiastic physicians who are willing to take a few seconds out of their encounter to refer the individuals who are eligible to programs, this was a godsend. But I can say that among many of my primary care colleagues, having yet another alert pop up on their screen during an encounter is not something they look forward to. But we did find that some practices did attempt this, were able to pull it off, and achieved high rates of enrollment. Finally, I want to emphasize the second important part of achieving success in prevention through community-based prevention programs is you must have a high rate of completion, which means that the patients who are enrolled in the program must be engaged. I want to share that the YMCA staff are extraordinarily professional and committed to their work, and that's why they have consistently high completion rates or participation rates, and Matt shared that information with us. And we think that this can be enhanced even more if there is two-way communication between the practice and the community-based program. So in the case of the YMCA, a report was sent back to the practice if the patients gave permission to contact their primary care doctor, detailing the names of the patients who were in the program, referred from that particular practice, and their progress in the program in terms of weight loss and participation in the number of sessions. And this kind of information that can be used by the practice staff to reinforce the importance of continuing to stay and engaged in the program is of great importance in boosting completion rates. That's all I have to say. This is a cool slide that I worked really hard on last night, so I wanted to share with you. The AMA is helping to build a bridge between clinics and between the YMCA. I'll be happy to take questions at the end. I think we've been instructed to type in the questions into the chat box, and then we'll take them at the end. Thank you.
Thank you, Omar. I'll take the ball back here. This is Matt Longjohn again from the Y, and I'll just add a few more thoughts here before we hopefully have some time here for Amy to take some questions from chat. I wanted to just expand upon this model and talk for a couple minutes about community integrated healthcare writ large, not just about the diabetes prevention program, but perhaps how to extrapolate from this experience and think about where other opportunities for transformation in the clinical setting are going to be appearing. As you may be aware, this is a slide that's kind of shown very often these days. We all know that maybe only 20% of modifiable health factors can be influenced inside the clinic. So thinking about the other 80% is where the community comes in. And CMMI, CMS recognizes this by framing many of their RFPs, including the Transforming Clinical Practices Initiative, around the notion of a community integrated healthcare system, which is focused on population-based health outcomes and a care system integration with community health resources. Assistant Secretary Anand Parekh in Health Affairs late last year described how he and other authors from HHS are identifying points of value that community-based organizations, or CBOs, can provide in a community health, integrated community healthcare system. And while there are many aspects of this diagram that I can vouch for, I have seen many Ys provide value to their healthcare partners in these very descriptive ways of partnership. I would tell you that there's a number of other areas as well, and I'll go into those in just a moment. At the YMCA of the USA, we really take seriously this idea of evidence-based interventions, and every program that we start scaling and connecting to the electronic medical record that we have to house all our data has had at least one randomized controlled trial behind it. Those are now represented on the screen that's in front of you. The YMCA's Diabetes Prevention Program is the furthest down the pathway of dissemination, but Enhanced Fitness is an arthritis self-management program. It's been scaled to a similar degree as the Diabetes Prevention Program and has been shown to save on average $945 per participant per year. The Live Strong at the YMCA program is a program where we have nearly 40,000 cancer survivors in the program, and a study that will be presented at the National Cancer Institute's biannual meeting in June will describe the outcomes that have been seen in that intervention, but it includes improved quality of life, self-esteem, physical fitness, and other outcomes. Moving for Better Balance is a falls prevention program, a Tai Chi-based program that is often actually bundled with our arthritis self-management program. We're starting to see orthopedists and others who are dealing with bundled payments for hip and knee replacements connect to WISE and utilize these evidence-based programs as part of pre- and post-operative routines to reduce risk of falls and readmissions and surgical complications. Our blood pressure self-monitoring program is one that's been developed in partnership with the American Medical Association, the American Heart Association, and the CDC, and we are just beginning to scale that, but it's based on a check it, change it model, showing statistically significant reductions in diastolic and systolic pressures, and other interventions that are in the process of being scaled. So we believe the diabetes prevention program is just kind of the tip of the spear here in the programs space. But what we also see is that beyond the evidence-based program, the self-management programs being part of the CBO value, community-based organization value that can be connected to healthcare, that there are other ways that WISE, at least, are being connected to healthcare providers and healthcare systems. Many communities around the country have had WISE with funding from Robert Wood Johnson Foundation or the CDC or other foundations be backbone organizations in collective impact models in those communities where community health needs assessments, which are produced by often the nonprofit healthcare system in the community, are translated into community action plans and ultimately utilized to implement policy systems and environmental changes in those communities and benchmark successes at the population health level. WISE have a whole training system behind them to help facilitate that kind of process. In the shared physical spaces aspect of community integrated health, we are seeing many WISE and healthcare systems go into either rental agreements or even build new facilities together to reduce barriers to access amongst the patient population. WISE are leasing clinical space to more and more healthcare providers for primary care and preventive service visits. And also WISE are becoming, in some cases, the front door of medical campuses and managing physical therapy and occupational therapy, for example, for healthcare partners. We even have examples of WISE and healthcare systems partnering together to rent space at the front of grocery stores or in other novel community settings to co-program in some interesting locations. So this is, I think, a part of community integrated health that is not yet described in HHS models, but which we are seeing and developing best practices for. WISE are also hiring nurses that are doing home health visits, making sure children, especially in the new American population, to get their shots before entering school, or to be checking what's in the pantry in doing home health visits for older adults, doing nutritional assessments. WISE are hiring community health workers. There's many aspects of this navigational supports part of the community integrated health model that WISE are participating in, and many other community-based organizations. And we have already talked about the evidence-based programs. With the support of the Robert Wood Johnson Foundation, YMCA of the USA is putting all these ideas together: collaboration, evidence-based programs, compliance workshops, technical assistance, navigation and shared spaces, technical assistance, as a provocative model to use to talk about what could happen if community-based organizations were more towards the middle of strategic plans and planning and thinking amongst healthcare providers. We are committed to helping other nationally networked community-based organizations learn lessons from our experiences, as well as helping to provide partnership technical assistance to providers like you who are on the phone today as part of the Transforming Clinical Practices initiative. As was mentioned by Amy at the outset of the call, we're a partner in that SAN grant and look forward to helping you as you move forward with your transformative efforts. The last slide here, I think is my last slide, is I do want to mention that in addition to all the other innovations that I had a chance to talk about today, our board at the national level has recognized how important this work is and has recently actually given us license to create within YMCA of the USA a management services organization that provides the administrative, business, and technology services to all of our federated WISE. So we can enter into contracts on behalf of our entire network when dealing with insurers, payers. We have, for example, an ACO in Ohio that is contracted for the service that we've talked about, the Diabetes Prevention Program, for all of their patients and employees all the Ys in Ohio are a part of that contract. So we can take many lessons learned from healthcare about how to organize these services and distribute them in partnership with healthcare partners, and that's what we're doing. As I turn it back over to Amy, I did just want to reply to Omar's query. It is true at the Y we are averaging a greater completion rate than was even projected. We have seen 86 to 83% retention rates in the program, and so it speaks to the ability to get people through the intervention if we could only get awareness built in the provider community for the need for referrals and ultimately the referrals. So with that being said, Amy, we'll turn it back over to you. It looks like we have a couple minutes left for questions.
Thanks so much, Matt and Omar. Yeah, we've got more questions than we're going to be able to get to today, but I'm going to start firing off a few to you right now. We've got some fantastic questions in the queue. Keep typing your questions in. If we don't get to your question, we'll get some answers posted to you up on our website. And of course, there's lots of resources. We posted the link to the WISE website. So first and foremost, as Matt mentioned, let's try to get everybody aware of these programs. I think that's one of the biggest hurdles we need to get over, and certainly the AMA has been a big help in that. And certainly through TCPI, we're going to try to share as many resources that we become familiar with that are available in the community that can help improve the health of populations. But so Matt, all right, we've got listeners on the call who went to the website. They found out that there's a program near them. What would be the next steps if they're a clinician? How do they start connecting? How do they start referring? What would you recommend?
Great question. So if you've been to the website and you found a Y near you, it's as easy as going to, normally there's either a link or a name of the local Y. So every Y typically has its own web page, or you can, and you can make a direct connection, or you can call the number that's on your screen, and we will connect you to a technical advisor who works with all our Ys and can help you make a warm handoff.
Fantastic. I think so much of that's really important. We've heard even through the questions that have been filed here, sometimes one of the biggest barriers is even if they know about a program, they're a little hesitant to make referrals because they don't know the qualifications of the people who are providing the services. They don't, even though they've seen some of the literature about the outcomes. What are some additional recommendations you can make on that front? What are some of the things that they can expect? I mean, do they need to link up to your electronic health record? Does the information flow easily from the WISE information database back to yours? What are some of the other kind of nuts and bolts?
Yeah, so to your first point about kind of the credentialing of the individuals delivering the intervention, within the Y system, every one of the several thousand lifestyle coaches that we have delivering the program have a minimum of 20 hours of training per year when they get started. That decreases a little bit over the course of a couple of years as certain things only need to be recertified every couple of years. HIPAA, for example, is a certification that they all have in place and keep current every year. And Omar, you may want to say something about how the providers you've worked with have also gained confidence, not just based on the WISE training system, but on the CDC training requirements.
Absolutely. One of the things that came up time and again in our conversations with healthcare providers was exactly what's being asked about the fidelity of the program. And I think that in the case of the YMCA, I'm quite confident that the program is definitely performing above the standards designated by the CDC. But the CDC, through its National Diabetes Prevention Program, has set up what's called the Diabetes Prevention Recognition Program. It has many components, but there are 2 or 3 that are relevant in order to convey the fidelity of information about the fidelity of the program. So the coaches have to be trained using a particular training that has been sanctioned and is vouched for by the CDC. And as Matt was acknowledging, the coaches also have to provide the service to a certain number of individuals to stay qualified to be lifestyle coaches in the program. The second piece is that the curriculum that is used in the program stays true to the evidence. And I think the Diabetes Prevention Recognition Program stipulates that only one of 5 or 6 CDC-approved curricula can be used, which is the case with YUSA. And finally, there is a component in the program of data being submitted to the CDC periodically. I think it's every 6 months, to show that the participants in the program, a certain number, are meeting the weight loss threshold. The Y, we know, has already implemented an even more rigorous system to assure standardization across the nation. So at least the worry that some clinicians might have in sending individuals into this program can be put to rest by reassuring them of all these different ways in which the CDC, and in the case of local YMCAs, the YUSA at the national office, all the steps that are being taken to ensure program fidelity. The referral piece is a bit tricky. We have seen different models play out where the practice instructed the patients to call the YMCA or shared lists of patients with the YMCA. I don't want to make an endorsement here, but some practices felt comfortable either with a business associates agreement or some other kind of understanding with their local YMCA with giving them a list of individuals. I can assure you that all the YMCAs we worked with were HIPAA compliant, and someone from the YMCA would then call the patients up. Very rarely, I think maybe one situation where we found that the electronic health record was hooked up to some kind of setup at the Y. But one thing which was used in a number of practices was an electronic fax that was built into the EHR. I think at least 2 of them, I can say with confidence, were able to use this to effectively refer patients, where the EHR had a structured form which had many of the items in the form pre-populated, and then pressing on a button would send an electronic fax to the local YMCA, which was a HIPAA secure fax, and the YMCA would act on that. So there are different ways in which practices are innovating to solve these issues.
Thank you. I will just add, I know we're almost out of time, Amy, but Omar's got it exactly right in terms of how the connection to an EHR was working in the time that we were doing this project together. It is only with this year's grant from the Robert Wood Johnson Foundation that we have been able to establish the partnership with a national EMR. So the innovation of actually having data already in a clinical record that through meaningful use and HL7, for example, can be communicated back and forth is coming online. So that is a new innovation that I was describing, and I'm glad, Omar, you had a chance to help clarify that.
Fantastic. Well, we are at the top of the hour, and I'm sad that we didn't get to more questions. But this, again, is just going to be the beginning of a lot of information that we're going to share as part of our work in TCPI and our partnerships across lots of different organizations. But what I think is really exciting is that in addition to TCPI, there are so many new innovation programs that are being announced, that are coming down the pike very soon, really validating the importance and the value of connecting with community partners to improve population health. And certainly lots more on the forefront, and we'll be hearing more about the new MACRA proposed rule that we'll start calling the Quality Payment Program. I think there's just a lot of new opportunities that we're going to see for clinicians to be really incentivized to make these connections to community partners much more formalized, as they're given more flexibility to expand their care team in different ways and really explore, based on the needs of the population that they're serving, where are the best places to serve them and through what different mechanisms and programs that they can utilize in ways that we've never seen before. So thank you so much, Omar and Matt. This was a fantastic conversation. Again, much more to follow. We'll have a copy of the slides up on our website by the end of the day tomorrow, along with some additional answers to your questions. Thanks so much, and we'll be talking with all of you soon. Bye-bye.